Hello and welcome to Access for the second in a series of programs with Rheba de Tornyay. Rheba de Tornyay is Professor and Dean Emeritus at the School of Nursing, the University of Washington in Seattle. She was the first president of the American Academy of Nursing, and she is a trustee emeritus of the Robert Wood Johnson Foundation, having served for 10 years as the first woman trustee. Okay, Rheba, you sent me an article a month or so ago called Being with Dying. Mm-hmm. And of course, being with dying is very much something a nurse has to do very often. And on this occasion, you sent it when you were very personally involved.
Exactly.
You were married for 55 years to Rudy
Right.
de Tornyay.
Yes.
And he died last year, I believe.
Last November.
Last November, right. And you had 2 years of hospice.
Yes.
Of hospice help with Rudy.
Yes.
I'd like you to tell us about that.
Oh, I'd be glad to tell you about it. There are few institutions that I can speak more highly of than hospice. First of all, hospice is a concept. It isn't a place. There are hospices that are part of institutions like nursing homes or hospitals, but more frequently they bring the services to you and the family. And Rudy was actually a hospice patient for 28 months, which is quite unusual. Most people are hospice patients for about 6 months. In fact, a physician needs to certify. It's a package of services that Medicare, by the way, pays for. They need to certify that the individual has a life-limiting situation. But of course, you never know how long people are going to live.
And I understand that with hospice, you get such good care. You live longer.
Yeah, you live longer. That's right. I don't think.
Yeah.
I don't know that Medicare planned it that way, but you do. You really do. And let me tell you what the differences are. Rudy had all kinds of diagnostic work done in an acute hospital. And when
this was in Seattle.
This was in Seattle, yeah. But what I'm going to say could happen anywhere in the sense that it was, you go from this acute situation, and it was like going out of, I hate to be so dramatic, but like going out of a tunnel into the light to go into hospice.
What do you mean by an acute situation?
Well, he had various symptoms that they needed to do all kinds of diagnostic tests to find out what was wrong with him. When they found out that his prognosis was not good, he did not want to continue with the diagnostic tests. He very logically said, he was 93 years old, he very logically said, look, whatever you find, I'm not about to go in for having a bunch of surgery and a bunch of things that I don't want to have. So what's the sense of going on and having these invasive types of tests that could create some problems for me? And since we think of ourselves as socially responsive individuals, or responsible individuals, he said they're very expensive, and so I don't want them. So he chose to go into hospice. And hospice has a team of people who come to the home. It always consists of a nurse and a social worker. There's also a spiritual advisor if you want one. There is also a nurse's assistant who will help with bathing and some of the kinds of other activities. And there are also various therapists, like occupational or physical therapists, for depending on the need. It's always guided by our own personal physician. So he doesn't abdicate his responsibilities with this at all. And Rudy and I were lucky enough to have an unusually sensitive and wonderful physician who came to visit Rudy at least once a month.
He made house calls.
He made house calls, which is very unusual. And so when you talk about people living longer, of course, they don't have the stress of having to go in anywhere and have their care. It's really brought to them. When I say it's unusual that Rudy was there for 22 months, I have to say that he went through 2 periods of time when they began to think that he might be in remission, and he almost was graduated twice.
Meaning out of hospice?
Out of hospice, that's right. And it's kind of a mixed feeling. Both Rudy and I mourned because we said, this is terrific, you're doing so well. But on the other hand, I, in particular, said, I can't cope with this all by myself. What am I going to do?
I want to ask you about that.
Yeah.
I mean, here you were, a nurse. You must have trained thousands of nurses in your life
I did.
as a dean and professor. And during that training, they're taught to deal with death and how to help
Yeah.
someone dying. And here was your husband with whom you were very happy for,
Yes.
for 55 years.
Right.
And you were taking care of him,
Yes.
even though you did have the help from
Yes.
hospice. May I ask you how that was? I mean, it's a
Oh,
very personal question. But
It's a personal question. I'm going to answer it honestly. It's very difficult because to every health professional knows that caring for your own family is probably more difficult than anyone else. And that is that in many respects, from Rudy's point of view, it forced him in some situations into dependency on me, and that was not a good feeling for him. And from my standpoint, I used to accuse him of treating the other people who took care of him better than they treated me, and which is kind of true. And
of course,
I thought
it's inevitable.
Yeah, it's inevitable. That's right.
Yeah.
And once I said to Rudy, "Why are you being so upset with me?" And he said, "Well, you're the only one here." And so I thought, well, that's really true. That was a difficult thing. The other thing that was very difficult for me as both a nurse and a wife was that I'd get those roles mixed up. And I've tried to talk to other health professionals, particularly nurses who were caring for loved ones, and find out if they had the same kind of reaction. And I must have been a pain in the neck for some people, because both the social worker, the hospice social worker, and our personal physician, mostly our personal physician, took me aside and he said, "Rheba, do me a favor." And I said, "What?" And he said, "Would you just please be a wife?" He said, "Just let us take care of Rudy, and kind of like you stay out of it." Because
Okay.
Yeah.
That might have been right in this situation.
Yeah.
But I sure don't want the doctors telling anyone close to me
Yeah.
to stay out of it if they're helping, because the doctors are so often wrong. And
Yeah.
or they're not as close to the situation,
Yeah.
or they have other priorities.
Yeah.
We don't all have doctors who are so lovely they come and, even if you're dying, and
Yeah.
make house calls.
Oh,
make
yeah.
regular house
Well, I'm
calls.
not going to sit here and tell you that everything was a bed of roses when Rudy was in the hospital.
Right.
Because I had one situation with a physician that was really pretty awful. I mean, pretty awful the way he treated me, because I had gone in, and this was in an emergency room, and I had gone in and told him that I was a registered nurse, and the moment I said it, I saw the look on his face, and I thought, oh, I'm in for a power struggle right now. And I was. And my only reason...
Well, what happened?
Well, just a minute, I'll get to that. My only reason for telling him that I was a nurse was credibility. That I could very briefly tell him what the situation was, and I wanted him to believe it. Well, the situation, I don't want to go into all of the gory details, but the situation was such that I had called the specialist that was caring for Rudy with the one special problem that he had. I had called a specialist, and the specialist said, bring him into the ER, and I'll meet you there. So we got into the ER, and the chief of the physician, the attending who was on duty that day, this is a teaching hospital, you understand, Dick, so therefore there are attendings who are the faculty, and then there are all these residents.
This is the University of Washington.
Yeah, right. Yeah, right.
Yeah.
And so I said to him, as soon as we got there, I said, Dr. So-and-so, who's the resident, asked to be called when he got in here. And so he snapped at me, the attending. He said, I make the decision as to when I call the specialist. And I said, yeah, but we were told that we should do this. And he said, let's get something very straight. First, the resident tries this procedure, and if he's unable to do it, then I try it. And then and only then will I call the resident. I call the specialist. Well, I didn't want Rudy subjected to all of this, and so I ended up calling our primary physician, who called him, who took care of it. Now, I was in a special situation. I'd been the dean in that institution, so I wasn't just unknown. And I have to make that point very clear. I seldom tried to do that, but under these circumstances where I had to make a choice of my husband being hurt or pulling rank,
Of course.
then I
Yeah.
pulled rank. And I feel kind of badly about it. I feel badly saying that to everybody because I should get no special attention or special anything, but I had to use it. So it's not that when you say that doctors are frequently wrong, yes, they are. I mean, and in terms of whatever it was, this was very bad behavior.
Well, what about the struggle between doctors and nurses? It seems age-old. I mean,
Yeah, it is age-old.
as a kid in the hospital having a minor operation, I even sensed it,
Yes.
the doctors and the nurses.
Yes.
Have you any comment you'd like to make on that? How's it going? How's the war game?
Is the war getting better? No, it isn't. No, it isn't. In some cases, it might be. A lot of that struggle between doctors and nurses, I used to always think was a male-female thing, but it's more than that, because there are more and more male nurses, and there are more and more female physicians. And so that is beginning to even its way out. There are no other professions that are linked together as closely as medicine and nursing. There's no other model anywhere because they're overlapping, tremendously overlapping roles. If there weren't overlapping roles, there'd be just big gaps that somebody would fall into. And so it's very hard. And one gets into power struggles as to part of the nurse's role is very much the nurse's role is to make sure that errors don't occur. Otherwise, if we were just following orders, nobody'd have to educate us. We could just follow orders. Anybody could follow the orders. So in my day as a young nurse, because I'm a totally different generation than the modern generation, I did all kinds of circuitous things. A physician would write an order that was not correct, and I would go up.
Such as, can you give us an
A
example?
medication error, for heaven's sakes. I mean,
They might give me strychnine instead of aspirin?
No. He might give you the wrong dose of a medication, which is contraindicated for something. Mostly it's a dosage situation.
Okay, all right.
And let's do that because it's a simple one for me to explain.
Sure.
So I would come up and I would say to the physician in a tactful way, I would say to him, perhaps I misunderstood your order, but did you mean this? Or did you mean this? And he'd say, oh, thank you very much. I meant the other. Now, the modern nurse is not as tactful because she's a different generation, or he's a different generation, and he'll go up and say to the doctor, I think this is wrong, or I think you made an error, or if they really don't like them, they'll say, for God's sake, you're trying to kill this patient, so it depends. They just do it in a softer, they do it in a more straightforward kind of a manner now. But, I have to mention, and I'm not defending anybody, or in a way I am defending everybody, they're very stressful jobs. And I noticed this when Rudy was in the hospital. I don't know that I could do it anymore. It was stressful in my day. But now everybody's in a hurry. There's so much confusion around. Things happen. Everybody is frazzled. There's always shortage of everybody, I can tell you that. There's always shortage of everybody, and supplies are never quite in the same place, or the place where they should be, so people get very upset. So I guess what I'm saying is there's two sides to that whole story, and we get cranky and we get mad at each other, and we're sorry, just like all human beings. Yeah.
Yeah, sure, I can see that happening. So hospitals are less efficient, more chaotic,
They probably tell you they're more efficient, but they are more chaotic.
Mm-hmm. Right. Okay. Long-term care, which is of course associated with you're very interested in long-term care. Yeah.
Yeah.
And we certainly see a lot of it in the community out here.
Yeah.
What is just make some comments on the status of long-term care as you see it and what's needed.
Oh, Well, you mentioned my interest. It's been my lifelong interest because in my practice days, that's what I did. And there is more of a need for long-term care today because it's, in a way, a mark of the success of modern medicine. People are living much longer, and therefore they have the needs for more care. And it's hard to get the long-term care. We're talking about people in the home. That's hard to find. There are various agencies that could provide the services. There are various situations where people go into private homes for care. The adult family homes, which are quite common on the West Coast. I don't know if they are here or not, but where this is probably is more desirable for many people than a nursing home because it's maybe 6 patients or residents cared for by the same people day in and day out, and they in a kind of a home environment with home cooked food and less regimented, and so that's a very popular type of thing. Nursing and assisted living facilities are also growing a great deal on the West Coast, and I myself am moving into a continuing care retirement community in the first of the year, which is being built now, which has all levels of care. It has independent living, so first I go into an apartment just like the condo that I'm now living in, and then after that, if I need to, they can provide, I can go to a special place for assistance, or they can provide assistance in my apartment, or the third level, of course, is a skilled nursing facility or a nursing home. Now, the problem with that, it's a wonderful solution for those of us who are alone. Rudy and I never had children, so I'm alone. It's a wonderful solution, but I have to say that they're very expensive, and not everyone can afford them.
We have them out here.
Oh, good.
Yeah, we have Peconic Landing,
Yes.
like that in
Yes.
North Fork. Yeah,
Yes, good.
right. So it's not ideal. Okay. You sent me another email. It interested me very much. You are still involved in the selection of scholarships of people
Yes.
who are applying for scholarships. Let's see if I have that. Hope I brought it. Yeah. No, didn't bring it. Okay. You recommended a scholarship for a young woman who had been very critical of agencies that she'd been training with, saying that the social workers were commenting on their clients as if they were a nuisance and that kind of thing. Now, have you had much encounter with that as a nurse, leading as a nurse? And do you find that fairly recent, or is that something you've encountered for a long time?
Well, it gets to into the area of patient autonomy. I think, if I remember correctly, the email that I
have it.
Oh, good. I'm glad, because she said it
Yeah,
so beautifully.
okay.
That's why I sent it to you.
Okay, I have it. I'm a chaotic. I have worked with this is from a young woman applying for a scholarship in your nursing.
No, this was through the retirement, if I may correct you. This was
sure.
from the University of Washington Retirement Association that offers 4 scholarships each year to students in any field who are headed for a career in caring for for the elderly.
Okay.
And I don't know what discipline she's coming from. They come from all of them, but most of them are nurses, social workers, or physicians. So go ahead.
Okay. I have worked with an older adult whose house was condemned by the city. His wife had chronic mental illness and had recently been placed in a skilled nursing facility. This gentleman was being identified by various agencies as non-compliant. Mm-hmm. They seemed frustrated with him. He needs to fill this out. He needs to go to Social Security, or I can't hold his hand. These were just a few of the statements I heard from the individuals who are actually being paid to help him. I worked with this gentleman on selling his house, which had to take place within a specific time or the city would take over the land. I then connected him with an individual who assisted him with purchasing a mobile home. This gentleman was not non-compliant. He was overwhelmed and scared, and yes, maybe even needed someone to hold his hand. He continues to maintain his new home and visit his wife daily. He never misses a care conference and is never late for appointments. How is that for non-compliance? And then I want to say what you added to that personally. Now you see why I've loved to teach for years. It gives me hope for the future. Yes, I recommended her for the scholarship, and you say she got it.
She got it. Yes, she did.
Yeah.
Yeah, I just thought, you know, that was sort of the reason I sent it to you, Dick, is because that's the kind of feel-good type of thing.
Right.
And then you say, you know, I often have wondered. I've wondered every year when I've watched our graduates in the nursing program walk across the stage to get their diploma. I've always said a little prayer to myself saying, just keep them that way, keep them excited, keep them wanting to help people. And many things in the system makes it very difficult to keep them that way.
Well, I'm sure it does.
Yeah.
I want to ask you something now that, of course, is in the area I've been working in out here,
Yes.
which is disability situations in
Right.
hospital. As disabilities officer for the town, I had complaints.
Yes.
Stony Brook Hospital, which isn't in the area, which is our nearest
Right.
major hospital, it's a long distance away. They didn't have an accessible bathroom, and they told a man who's wheelchair bound to go out into the parking lot to urinate for his sample.
Oh, gosh.
Yeah.
That is really shocking.
Even
Yes.
you?
Oh, yeah, even me, especially me. That's terrible.
Yeah. And I found with my hearing problem situations where, for example, I was in the intensive care unit at Southampton Hospital some years ago. I imagine they've corrected this now, where I had it put on my chart that I was hard of hearing. I was hooked up, my heart was hooked up, and they came in and I was to urinate, and instead of staying in bed, I got up on my knees, and the nurse screamed at me because she said she told me, to do it lying down.
Yeah.
Situations like that. We've also had, it took a long time for a local hospital to get a Latino interpreter.
Yeah.
I mean, what is a situation that hospitals seem to be behind the curve somehow in this sort of thing where you think there are obvious steps to be taken, they're not expensive, they're not difficult. What is the nature of the hospital and the relationship with the nursing profession that we have this side of it too? We have wonderful sides, but we have this side of it too.
I can't give you a quick answer to that. I don't know that I can give you any answer to that. I would say that an awful lot of it depends on the management of the institution, frankly. I mean, it always comes down to people. Mostly it comes down to people. Those are shocking examples. I could add to them in terms of my own personal experiences. I sort of feel like, it's not my role to sit here and apologize for the Southampton Hospital, but...
Well, you live a little distance.
I live a little distance, but as a nurse, I feel like apologizing because I don't like to see this kind of thing happening. I'm embarrassed. I'm embarrassed to hear that kind of story. And I don't know what the answer to that is. This is why I said, as I watched our young graduates cross that stage, I say a little prayer for them, not to happen to them. It is very easy to become calloused and hard and routined, etc., and that's a very bad thing to have happen. I mean, that's all. That's not an answer for whatever it is.
Well, one bright spot you see and emphasize are nurse practitioners. You think they can make a really...
Well, nurse practitioners are different than the nurses that you were talking about in the intensive care unit.
But aren't they trained at some point as nurses?
Oh, yes, they're trained as nurses, but their role is different. Nurse practitioners deal predominantly, they cross more over into making some of the decisions that heretofore only physicians made. For example, they are more into the diagnostic treatment type of thing, where not that the intensive care nurse isn't, but their roles are somewhat different. And frankly, they're good and bad in everybody.
But it's a whole new section of medical care, isn't it?
Yes.
And it seems a very positive one, too.
I think so.
And they're trained originally as nurses, and then...
Oh, yes.
Yeah.
They're trained originally as nurses, then they go and they get a master's degree, and then they either are in primary care, which means they're the person that you see on a consistent basis, or they're nurse practitioners who work. I go to a dermatology nurse practitioner.
I do too.
And she takes care of me, and always the dermatologist. She could refer to the dermatologist if she needs to, but mostly I don't see him.
Right. Okay, Rheba. There's a lot of things that I was wanting to discuss. You know, for example, dentistry. In a half a minute.
Oh, in a half a minute. You know how little I know about dentistry.
No, the connection between.
Oh, the connection
between dentistry and medicine and hospitals and you know, and public health and that kind of thing.
Yeah.
Yeah. Okay.
Okay.
Well, since you can't do it in a half a minute.
No, we can't do that in half a minute.
Okay. Thank you. Rheba Tornyay, Dean Emeritus and Professor at the University of Washington School of Nursing. It's been wonderful being able to...
Thank you very much. It's been wonderful being here.
Really being able to interview you like this, and you've added so much to the program. And,
Thank you.
And I really appreciate it. Okay.
Okay.
That's right. Yeah, no, really, that was lovely.
Do we talk or do we just...
We can do anything. Anything